Thank you all for joining us today for this Lunch and Learn as we discuss the complexities and the weight of the discussions between patients or caregivers and their providers as they navigate through diagnosis and consider gene therapy clinical trials. My name is Ali Kajowski. I'm the Senior Outreach Manager here at ASGCT. I'm pleased to walk us through this discussion today between two wonderful speakers who have tons of experience in this space. Um, Today, I would like to acknowledge the following people and their ancestors whose land we are on today in Waukesha, Wisconsin area and were displaced. Thank you. This is the ninth session of the series thus far. We've covered many different topics over 2022, which were intended to build on one another. For example, last month we featured an inspiring panel of researchers who shared more about their work. All previous sessions are available to watch on demand at patienteducation.asgct.org. So please feel free to go back and learn from a lot of the valuable content we have. This site also contains a whole library of Gene Therapy 101 and disease specific content that is free for all to access and share. We recently redid the first ever units we created on gene therapy basics and the clinical trials process. So please go and check these out. They're updated, accurate, reliable content, and we look forward to sharing them with you. Today, we have the pleasure of hearing and learning from first Dr. Caitlin Young Batley, an assistant professor at UT Southwestern, and Jennifer Seidman, joining us as both a parent and the director of community engagement at the Courageous Parent Network. After we hear introductions from both of them, the majority of this session will be spent for discussion. So please don't forget to submit questions to the Q&A. We look forward to discussing with you. I will hand it over to Dr. Batley.
Hi, everyone. Good morning. Thank you so much for tuning in today to have a little discussion about kind of the things that go into getting started with a gene therapy or a rare diagnosis, and kind of how we work through these processes as a team, as both the medical providers and the families. And so I'm Caitlin Batley, and I am a pediatric neuromuscular neurologist, and I work at the University of Texas Southwestern in Dallas, Texas. And there's my contact information on the slide. If there's anything I can help with after the lecture, please feel free to send me an email. So just a little background on kind of where I'm coming from. As a neuromuscular neurologist, I see different disorders that affect the peripheral nervous system. So that includes disorders of the motor neuron, the nerve, the neuromuscular junction, and the muscle. And so I'll often see these patients either as a new diagnosis, so coming to me with new symptoms and kind of no explanation yet as to why, and work through that diagnostic process with my families to come to a conclusion. And then after that, working through how we make decisions on treatment and whether there could be a commercial drug available versus going forward with a clinical trial. And so we have a lot of discussions about how to pick different clinical trials and which one is right for each child. And then although I spend the bulk of my time as a clinician, I also do participate in clinical research. And so have experience as well as getting started in trials and enrolling and kind of what goes into that process too. So I'll be happy to talk a little bit more about that as well. And so we thought we'd kind of walk all the way through this process with you all. And so typically when we're talking about making a diagnosis, there will be a concern that is noticed by either the parent or the pediatrician at a regular follow-up visit that can lead to referral to a specialist often. But we all know that this is not a perfect system or a perfect process, and that referrals to specialists can lead to appointments that are months and months away. And so there can be a very long time to kind of wait and wonder, which can be really difficult. And then sometimes getting to one specialist can kind of lead you in a different direction, lead to a referral to a different specialist who maybe is getting closer to finding out what's going on. And so this can be kind of a multi-step multi-step process where you're having to go see a lot of different doctors, a lot of different kinds of doctors. And then at each doctor, there will be kind of going through the whole story, taking the history of what's been going on and what the concerns are, as well as a physical exam. And then each specialist may order different kinds of diagnostic tests. And typically when we work through these tests, we try to work in a stepwise process. So that way we're, starting with the test that we think is the most likely to give us the information that we need. And then based on that, kind of continuing to explore other options. A lot of the times this can involve imaging, but with little children, when we try to get an MRI scan, it requires you to be still for a prolonged period of time with no movement at all. And so often this will need to be done with sedation or anesthesia to help our children stay still. And so it can take weeks to get that scheduled in some cases. And then some children will get genetic testing, which again can take weeks to sometimes even months to get a result back. And then there can be some more invasive tests. Some of the ones that I use in my clinic are things like skin biopsies, muscle biopsies, or EMG nerve conduction studies, which are electrical tests of the nerves and muscles. And same thing there. These can take weeks to get scheduled, and then sometimes another few weeks to months to get results. And so in addition to this being a really time-intensive process, it can also be really expensive as well. Insurance companies don't always cover each recommended test, or may have certain stipulations that can limit what the medical team is able to do at that certain time. And so that's yet another hurdle. And then, of course, even after going through all of these different processes and doing our best to find an answer, sometimes because of where we're at in medicine, we're still not able to yield a diagnosis, and we still, walk through this and don't have the answer. This is something that changes with time. So often it is worthwhile to go back and look at these tests again, because we're learning more and more each day. New genes are being discovered and new conditions are being named. And so it can be that what we don't know today is something that maybe in a few years we will know. And so this can take just an incredible and kind of unimaginable amount of patience on the side of the families to kind of keep reevaluating and keep coming back to this diagnostic process. And that can be really difficult. If we are able to find a diagnosis and be able to explain what's going on, then the next step is always, what can we do to help? What kind of treatments are available, and where can we go from here? So for some conditions, there will be medicines that are available that your doctor is able to simply write a prescription for. And those would be the commercially available treatments, medicines that are approved already by the FDA. But especially in the rare disease world, there are more often times where there are no yet treatments that have been discovered. And so clinical trials can be a great option. And so clinical trials are awesome because they can allow us to advance our understanding and treatment in different rare disorders. And then they can also allow patients to earlier access therapies that could potentially be beneficial with these investigational drugs. So just a brief note again on kind of the timeline of the clinical trial process. Clinical trials will begin with phase 1. Usually this is a safety-oriented set of the study, and they test the medication in a small group of people and try to just make sure that it's safe. This can last several months. And then if it is seems to be safe, then they'll move on to phase 2, where they, again, are always looking at safety, but begin to look a little bit more at efficacy, or how well the drug could potentially work. This part of the trial can go on for months to a couple of years. And then moving on to the next stage would be the phase 3 trials, again, looking even more intensely at efficacy, always keeping safety in mind as well. And then sometimes comparing this medicine to any others that might already be standard of care to see, could this be a better medicine than what's already available? And the timeline for this part of the process can take several years as well. And so we wanted to go over this briefly just to kind of emphasize the fact that this process, just like the diagnostic process, can be longer than we like at times. And so, as we're going through this process, there are a lot of different ways that families and clinicians can find information. Clinicaltrials.gov is always one of the most trustworthy sites to see what trials are available at that current time. Many disease-specific organizations will also have a lot of great information on their websites and listservs about what's available, what could be coming closely in preclinical trials. And then parents will often be able to connect with other parents through more informal groups, things like Facebook groups, where they can also get some information. The medical team can also be a great source to discuss different trials or potential treatments. And then the families themselves are often the best source of information for clinicians to let them know what they've found, what they've seen on some of these organizations, and to really be able to kind of make this a complete team where we're all working together. And so that's kind of the things that we run through at the beginning as we're moving through this process. And so I'm looking forward to some of our discussion a little later on. Thank you so much.
Thank you so much, Dr. Batley. That was a really great overview to get us started. Next, we'll hear from Jennifer Seidman as she dives more into her story and the psychosocial emotional state of people going through this process.
Thanks, Allison, and thanks ASGCT for inviting me here today. And Dr. Bailey, thanks for such a great little introduction to the whole concept of participating in therapies, and especially highlighting how onerous the diagnostic process can be, and just how long that clinical trial process also is, because I know that this is sort of something that families bump up against a lot of the time, and give families some emotional distress. So let me frame a little bit how I come to this conversation. I'm mom to three kids. My middle son, Benjamin, was diagnosed with Sanfilippo syndrome in 1997 at the age of 15 months old. His diagnosis at the time at such a young age was extraordinarily rare in Sanfilippo. And I will say that in 1997, the science into treatments for his disorder was also very, very basic. I'm not sure that's something I realized at the time, but in hindsight, I can see how basic it was. In fact, we could only identify 5 research labs worldwide focusing on his disorder at the time. And while my husband and I were naturally devastated by Benjamin's diagnosis, we actually thought of his early diagnosis as an opportunity, not just to provide for Ben's developmental needs, but to change the course of the science. And so we did what a lot of families do, actually. We founded a foundation called Ben's Dream, the Sanfilippo Research Foundation, and we started to attach our hopes, and I think I mention that word specifically right now because later on we'll talk about hopes and expectations on a cure, and started funding science. It really was our panacea for coping with my son's diagnosis, and we dove full speed ahead into it. The photo there on the left that says Hope for a Cure is from our first big fundraising effort, which was a nationwide appearance by families across the United States in news stories that aired after the very popular show ER, for those of you who are in my generation. The photo on the right with Ben in his little Ben's Dream t-shirt is him at about age 7. I wanted to include this photo because this is the time when I started to have a suspicion. Now, we had been fundraising, for 5 years at this point, and following research pretty aggressively, my husband and I. But this was the time that I started to have a suspicion that science was not going to develop in time for Ben. And it was devastating. And I wanted to mention it here today because one of the things I realize now, on some 20 years later, is that we still don't do enough to educate families about the process itself, the length of time it takes, and how we talk about families' hopes and expectations around developing treatments. Despite this little suspicion that I had that it wasn't going to come in time, my husband and I remained focused on following the research and funding cures. And in fact, that middle picture there of Ben and I is from an article that was published in the Wall Street Journal as we were funding a natural history study at Nationwide Children's Hospital in anticipation of a gene therapy trial for research that was primarily begun by Dr. Hyann Food at Nationwide Children's Hospital. My husband and I, early on in our work with our foundation and watching science, had sort of determined with our scientific advisory board that we felt gene therapy was going to give the best promise to kids with Sanfilippo. Even though as we were doing this, there were enzyme replacement therapies and other therapies coming on board. And so I say this because we were very invested in gene therapy, which is the topic we're going to talk about today, obviously. It was this time when the natural history study sort of came on board that I started to really see a path towards clinical trials becoming a reality for my community. I knew at this point it was not going to be a reality for my son. He had progressed too far in the disease, but I was determined to make it one for a lot of families that were still, in that position where their child might be able to participate. In fact, I wrote in a newsletter just after the natural history study um, started, this little quote that I think speaks a lot for how a lot of families feel when they recognize that the time might not meet their child. And so I just want to read it to you. The promise of a treatment is closer than it has been in more than the decade that we have been funding and searching for one. Dr. Fu's research presents me with perhaps the greatest personal challenge of my life. It is a challenge of hope, perseverance, and dedication. Her treatment and the science she applies needs more time, and time is not the friend of a rare disease family. About 1 month after Ben died in 2014, I actually spoke at the RAC meeting, and it was just a year or so later that the first child with Sanfilippo syndrome received gene therapy. That gene therapy has hit its own hurdles in the years since, and we can talk a little bit about that later. But that sort of frames my personal background and how I come to this discussion. Shortly after my son Benjamin died, I was interviewed by an organization, a nonprofit called Courageous Parents Network. And I want to just tell you a little bit about that because I think it could be a resource for everyone that's in the audience today. And I now work there as the director of community engagement, as Allison said. So Courageous Parents Network is a web and mobile resource for parents caring for children with life-limiting illness. Our website features the voices of parents and providers who care for these children, talking about many of the issues that families face, from caring for the siblings to marriage to understanding what anticipatory grief is or what a change in baseline means when your provider talks about that, to discussing things like interventions like spinal fusion surgery or feeding tubes. Through videos and blogs and podcasts, and we have even little curated learning modules that you can participate in and professionally reviewed guides, we explore what is often overlooked in our medical system, and that's the psychosocial and emotional considerations of all of these topics. And that is my husband and I right there in a screen grab of our initial interview that we did with CPN. And I think the little quote underneath speaks volumes because it's important to recognize that when families use fundraising as the panacea and the goal and the driving force to get to what has resulted in a lot of very good science, they are also often facing things that they aren't necessarily emotionally ready for. And when I first came on board at CPN, I recognized that I could take my experience that I went through with my community and watching them and working with them as we went towards a clinical trial to think about the support mechanisms that families needed to really understand what participation in a trial meant. And to not only learn to adjust their expectations around things like inclusion criteria, which can be both um, heartbreaking for families and rewarding when you realize your child, you might realize your child is going to meet those criteria. You might realize that they may not meet those criteria. how to support families as they relocated for a trial, how to support those families who, with gene therapy, faced the inevitability that their child may have an antibody and couldn't participate in the trial and they would be excluded. So, sort of all of those psychosocial and emotional components of clinical trials, because there's a lot out there and a lot of excellent stuff at ASGCT that tell us about the hows and the, what a phase 1 is and a phase 2 is. But there's not a lot that talks about, for example, how does a family evaluate their willingness to accept the risk of participating in a low dose clinical trial when they know the efficacy might be marginal? And how do they evaluate waiting to participate in the next trial because at that point their child may not qualify? So we address all of those kind of issues around clinical trials head on. Just to give you a little bit of knowledge about the depth of this unit that you can look at, there are 70 video segments, 3 podcasts, 3 guides, 6 blogs, including one of a mom speaking about a trial that ended and a father speaking about choosing not to have his child participate in a trial, and a very rigorous and a thorough curated pathway. We, of course, are always seeking to add to this unit, but I wanted to let you know that it's out there as a resource for all of you. Finally, I thought I'd sum it up and begin our discussion today with this great quote by Atul Gawande, who is both a physician and an author. And his work, while largely focused on elder care, I think is really relevant today, because these two questions are, I think, what we're really going to talk about today, which is how do we help families understand what the situation is and the potential outcomes? And how do we help them understand what their fears are and what their hopes are? And I'm looking forward to having a conversation back and forth with Allison and Dr. Bately. Thank you.
Thank you so much, Jennifer. Your work is just incredible, and especially everything that you've been through. I can only imagine how much it's helping so many other families. So I think as we're talking about navigating a discussion and conversation between a caregiver or a person with a disease and a provider, um, I think just off the bat, let's start from the beginning. So if you're walking into a conversation, whether that be diagnosis or potential treatments, I mean, what's some information that the patient or caregiver can bring to the table to contribute toward shared decision making? And then also, like, what can they expect if they're talking to a primary provider versus a specialist? Those conversations might look a little different.
Yeah, and I guess the answer to that depends kind of where we are in the process, and again, who the family is speaking with. So let's start off kind of in the beginning of the process when we are kind of learning about the diagnosis. That might be the time where the family is really, needing to kind of absorb a lot of information. And so at those visits, the best thing that we can ask is for families to come kind of, emotionally prepared to discuss difficult things, and as much as you can be. And, notepad, I always hand out paper at my visits because taking notes is huge. And to just kind of be able to go through all of those things one step at a time. And then at the, subsequent visits, because I like to try to see patients again relatively quickly, so that way, we can go over things again, because it's just too much to go over at one time and have it all, be absorbed. And so then at subsequent visits, I love when families are able to come with, the things they've read about online, or the different things that they've heard from other families, or whatever is on their mind, just so that we can have a full discussion. Because I would never want a family to think, oh, well, Dr. Batley didn't bring that up with me, so I don't want to bring it up. But I love that. I love when families come with these things. That way we can talk about why that might be good for their child, or maybe why I don't think it would be as good, but still having that, again, that team approach, so that way we're all talking about every concern. And so that's what I love to see in my visits.
Dr. Bately, I love how that how you, in your statement, recognized that the parent is in some ways often the expert, even when they come in that vulnerable situation just after diagnosis. They are still the expert on their child, and they can at times be more knowledgeable than the physician sitting in front of them, and even around a topic like clinical trials, and that's largely because of the internet. But and I really think that that's the first step in any shared decision making discussion between a provider and a patient, regardless of what the topic is. And I, like Dr. Bately, believe that, where the patient is in their diagnostic and sort of disease journey matters, especially around clinical trials. So that diagnosis, the family isn't going to have as much basic knowledge. If it's later when the child is, progressed through the disease and the family has sort of legs under them about the disease a little bit more, the approaches might be different. But um, I think some recommendations I would have for families is I usually tell families is if this is a big decision making point, bring an extra set of ears. Someone who is not going to be as emotional as the parent might be, or the patient themselves if they can participate. Nowadays, don't be afraid to ask if you can use your phone because you might think you have the capacity to write everything down, but you get home, can't remember, you don't know what you wrote messy. Take advantage of those mobile devices that we all carry around. Make a fact sheet about your child, what you would want this provider to know about your child, because ultimately they have to know your child before you can make the right decision about any therapy, and they have to know your family, and they have to know your priorities, and all of those things need to factor in when making those decisions. um, you might learn that a trial is, you know across the country, and you have to relocate to get there, and you might not be willing to split your family apart in order to do that. So having the provider know your family and your child is really important. And then I will just mention this because these are resources. We do have a guide on shared decision making on CPN, and a guide about attending a family meeting, and one about questions to ask if you're specifically speaking about a clinical trial. And so I think find those resources and put them all together and go in. I don't want to say with your guns loaded because that makes you sound like you're being defensive, but rather as prepared as you can be. And then the other thing I want to point out is shared decision making also means admitting what you don't know on both ends. So it's okay for you as the parent to admit there's something you don't know, but it's equally okay as a provider to say, I don't know if there's another therapy out there right now, but let's figure out how we're going to figure that out. And oftentimes the best solutions come when you start at that equilibrium.
I totally agree. There's been many a visit where, a family has come to me and said, have you heard about this trial coming? And it'll be maybe one that I'm not familiar with, and they'll send me the info on it. And I love that because it really is a team effort. Our families are able to focus so much on understanding one disease and all of the research coming so in depth. And so I appreciate and I value that they are able to bring their expertise, and that we can do this together. I feel very lucky.
Wow, that was really wonderful advice. I love those different ideas of ways you can just try to remember information. There's a lot going on. Extra set of ears, just really great advice. Um, so, as clinical trials are often tricky, they're unfamiliar to parents a lot of times, and they're sometimes unfamiliar to providers at this point. So, what advice would you give if a parent wants to bring up a clinical trial to a provider and the provider seems dismissive or unsure how to talk about it, and they're almost feeling like they can't pursue that option? And then likewise, I mean, how can providers become more comfortable talking about clinical trials or referring to them?
Um, I, I think that hopefully that doesn't happen, but I do recognize that that families experience these things, although it makes me sad to hear. But I do think that there are resources that are available everywhere for clinical trials. If you go on clinicaltrials.gov and you find it, there will be a contact information for who's running the trial. And so reaching out to them directly is always a possibility, both for the physician as well as the family. And so that's sometimes how I'll get more information about a trial, is just by reaching out there. And so families can do the same thing, and then can discuss it more in detail from the people who are actually leading the trial.
Yeah, Alice and I meant to look it up before today, but the Child Neurology Foundation did just put out a statistic about how many, there's a statistic about the number of providers who are actually uncomfortable talking about a clinical trial situation. And in some regard, that's because they don't know all the details of the trial, right? Trials are very specific protocols, and they might not be really adept at speaking to them. Calling somebody, the study coordinator from the trial site, either the physician themselves, let's hope they take the lead and do that for their patient, but the patient can, as Dr. Bailey said, can always call themselves. Um, and the other thing that I would say is, as unfortunate as it is that families experience providers that aren't comfortable talking about clinical trials or aren't knowledgeable about them, they need to also equip themselves with the capacity to move past that researcher. This is what my husband and I experienced. We went to the expert here in the Boston area at the time. He said, "There's nothing you can do for your child." We told him about a research that was going out in Minnesota and asked him to make an introduction to that researcher. He wasn't comfortable doing that. We left. We never went back to him again. We went out to Minnesota. We called Minnesota. We went out there on our own. It's unfortunate because families shouldn't have that burden, but we do. And so what we have to do is equip ourselves. And the other thing I would say is lean back onto genetics counselors if you don't get an answer from a physician that you're looking for, because they generally will dig a little deeper. That's the space they swim in. So that's just a little tidbit.
Great. Yeah, I mean, I hope no one experiences that, but I think the reality is that it's going to happen until more people are familiar with this space and this tons of research happening. Um, so as we dive in more specifically to gene therapy clinical trials, there's a lot of times families might be faced with a really difficult decision, whether they should start a treatment now or if they should wait for gene therapy to be available for their child or to be approved by the FDA. So can you guys speak more to this, what this decision is and what it might look like, and how we can kind of work through that and what those options might be?
Yeah, so I'll just give a little story from my personal life first, just because it's a little dated and not all around gene therapy, but it is about that inflection point where a family might have to choose, and what the struggle is and what the byproducts can be. So around about the time my son was 6, bone marrow transplant, stem cell replacement therapy for his disease came on board. And there were a lot of risks involved in that, including a number of children who died during the process. And my husband and I had to sit down and really decide, was this something that we wanted Benjamin to participate in? Were we willing to risk this somewhat healthy 5-year-old sitting in front of us in a very dangerous process? Were we willing to lose the years that we could have, even if he still died from Sanfilippo anyway? And then also, because we were pretty educated by this point in science, we started to have an understanding that him participating in this particular trial may make it so that in future trials he would not be able to participate. And so ultimately we chose not to have him participate in that trial, but it was a critical turning point for me emotionally, and I think in the way my husband and I approached my son's care. And this is very important to note, because what happens to these families is they're making decisions all the time. Caregivers are inundated with decision making. These big ones can be very onerous, and decisional regret is something that is actually can worsen any kind of grief that might come later, and can plague families. So what we want to do is set them up to make the decisions that are best for them. And so families are faced with this real reality, and then they're faced with the reality, and I spoke a little bit about this in my interview, of if I choose right now, for example, with the gene therapy, which was the case in my disease space, it was a dose, phase 1 low dose, phase 2 increasing dose, a dose escalating study. Sorry, the term escaped me for a minute. But and I worked with families who were asked to participate in the low dose trial and had to think about, am I willing to do this when I know the efficacy may not be the greatest? And am I willing to risk that if I wait, my child may not meet the inclusion criteria for the phase 2? And how do you bear that responsibility? It can be very traumatizing for families, and we need to recognize that, all of us who work in the science and support them out in the field, like Dr. Bately, and say, what extra tools can we give them? And at CPN, we say you got to name it to tame it. So we to lay it on the table, and I would invite everybody, when the families are in that situation, to really put it all out there for them.
And Jennifer sums it up better than I ever could with sharing what her firsthand experience has been. But I just have to echo that these are they're impossible decisions, because there is no way to know if it's the perfect choice. And so we do the best that we can, and we carefully weigh potential pros, potential cons. We have to talk about where each child is at in their disease process. And so, like Jennifer mentioned, if we wait much longer, would a clinical trial no longer maybe be an option, and would we miss this time slot? And so, do we pursue a treatment that may be pretty good, knowing that maybe later on something that's really good could not be an option? And so, yes, these are just really hard decisions, but we have to just kind of carefully talk about each little detail. And again, this is where a total team approach is necessary, because it's not a decision that I can make for any of my patients. And so we have to kind of work together and make sure that we are, honoring what is most important to each family. And so, yeah, difficult discussion.
Yeah, and I think saying it over and over and over again for families is really, really important. I mean, I also have just was working with a family who didn't really understand that gene therapy was currently, as it stands in its scientific process, a once and done opportunity, and that they couldn't just get a booster at some point later on, if the efficacy did not turn out to be what they wanted it to be, and why they couldn't. And I think it takes a lot of different ways of explaining that to families. And I think also there are providers out there that also need to learn what that process is, so that, for example, the pediatrician is able to have that conversation secondary to the specialist that's having it to them, and reinforce it along the path.
Yeah, definitely. Decisions with so much weight. I love that idea of just talking about it many times and many times through. I think that can help a lot of people catch things they didn't catch the first time and let it really sink in, depending on what you might be hearing and what you don't want to hear. Can probably change the message a lot. Um, so when a person is talking about a clinical trial, I mean, let's say they have decided or they're really set on something, can you share a time or a situation you know of where how it should be handled when someone isn't eligible for a trial that they thought they would be? And then vice versa. I mean, there can be a lot of skepticism around trials too. You're putting yourself or your child at risk, and maybe some unknown risks. So, what if a trial is the best option and someone's really skeptical and it really is something they should consider? I think there's two sides to the spectrum. Um, if you have any insight on how that works.
And I've had both of those conversations somewhat recently with different families of boys with Duchenne muscular dystrophy, in which gene therapy is a really big thing. And so with one family, speaking with them about their son not meeting inclusion criteria, which was really, really difficult and obviously devastating for them to hear, because this was a treatment they were really hoping to pursue. And they rightfully so, when I talked about that with them, they were angry, and I don't blame them. And although I didn't set the inclusion criteria, I can totally feel with them, why this is disappointing and why it would make you angry. And they felt like that it wasn't fair. And so we did talk about, although I don't know if this helps or not, but why it's important to have those inclusion and exclusion criteria.
Mm.
And it's because the companies are looking for a very kind of homogeneous group of patients who all kind of can have about the same in their disease course, about the same strength, about the same age, and all of these little things, so that they can make sure that the group that gets the medicine is similar to the group that gets the placebo or doesn't get the medicine. So that way, when they're able to compare them over time and see how one group does compared to the other, then they can, if there's a difference, really say it was because of the medicine. And then that leads to maybe an increased chance that this medicine will get approved by the FDA and be commercially available sooner. Whereas we've seen in some trials that maybe those groups weren't so well matched in the beginning. And then, maybe the group who didn't get the medicine was stronger to start. And then the group who, did get the medicine was a little bit weaker. And so then over time, they kind of looked the same. And was it because the medicine didn't work, or was it because they were two different groups of people? And so then that delayed the ability of this medicine to go to the FDA and, be able to get approved. And so although it probably doesn't make it any better for each individual family who's facing that, there is a reason, and that's what it is. So that way there's the highest chance of getting this approved as quickly as possible to help out the entire community. But that's one of my least favorite conversations to have, because it's really difficult for the family.
Yeah, I mean, we hear all the time at CPN when we talk with families about the clinical trial experience that that specific conversation is as bad as diagnosis day. So psychologically, this is what the families are feeling. But the other thing that we have heard is that the families who best understand the process of science before they get to that point of being in the meeting where they're talking about their child not meeting the inclusion criteria are the ones who are more resilient around the conversation. So all of those points that Dr. Bately made about why the science has to be what it is are vitally important as communities of disease spaces and new research comes on board. Like I tell people all the time, the more you can talk about that as you're leading into the reality of a clinical trial in your disease space, the better equipped your community is going to be as they come into it. Because part of it is how much we attach treatments to hope. And we do it in fundraising, and we can talk about that for ad nauseum. But that is part of what factors into the psychosocial and emotional part. But I know, Allison, you had that second half of your question, which is, how do you help that family who's gun shy about participating, even though their child qualifies? And that goes back to sometimes it's about the science, right? In my particular instance, the example I gave, I had some expectation that gene therapy was going to be a more effective process if it came on board, right? And so it's a hard, like I haven't had to really have that conversation other than with families in my community where they did say, well, do I participate in this current enzyme replacement therapy because there was one just as our gene therapy was coming on board, or do I um, go into waiting for gene therapy? And then how and then also there were multiple gene therapies, so then which one was more dangerous? And so um, I think the one thing that we can do to help caregivers as they're thinking about this is having constant conversations, not just ones as they're in that appointment, about the family's aversion to risk. What is their willingness to risk? Because if they can evaluate that separate of the clinical trial, because caregivers are taking on risk on behalf of their children all of the time. They're making really high stakes decisions a lot of the time. So when a family comes to that discussion with more understanding, sometimes they have less hesitation because they've already had a chance to really think about their own value around that particular topic.
Yeah, really great advice on both ends. I really like the idea of Dr. Batley. You explained how providers can explain inclusion and exclusion criteria, and that can really help someone understand it's the why behind it, which could help with coping maybe in some ways. And uh, so, and you both kind of touched on this theme, and we hear this theme a lot, but realistic expectations. So, when you're having these difficult conversations, um, like, can you explain how important realistic expectations on time and outcomes and the process, how important that is to really highlight through all of these discussions?
Yes, and I think that's the one thing that I have recently, started placing even more emphasis on because as our, social networking and, communities are just, so built up and so robust, our patients are hearing more about, what's going on in the research arena. And some of these things we're hearing a lot of buzz about because they sound so amazing, but they might still be kind of preclinical or maybe in animal models, and kind of explaining that this could be something that could be, even years away in some cases, or sometimes these sound really, really promising. And then when we get towards, starting the clinical trial, there might be a safety issue or something that even, keeps it from moving forward. And so, this kind of ongoing discussion about how, although these sound very great and we're really hopeful, not all of these things will be a possibility, and being able to kind of just constantly remember that that we may have to kind of readjust and we may need to shift our focus towards something else if these things that that the family is hoping for don't come to us.
Hmm. Yeah, I mean, it's a big topic that we talk about at CPN all the time, hope and expectation. And as I said, I'm a big proponent that in all of our conversations with physicians, we need to, and more and more now, I advocate that even disease organizations need to move away from, and I'm guilty of this because I use the word hope fundraising all the time, move away from that attachment of hope and move it to a cure or to a treatment, even though that is our hope, because what we want to do is we are working towards the expectation of getting that one, and our hope is fluid. We can change our hope as we go on. And in my example, I pointed out when Ben was, in that t-shirt, and I was getting the suspicion that he was not going to qualify for, the science wasn't going to come in time for him. And part of that was that no one had ever really explained the process to me. Like, I remember at that point, Dr. Fuad had submitted for an IND, and I thought that was like, all right, we're on the cusp of a clinical trial. Well, we were lots of steps away from from a clinical trial. And no one, I didn't understand the process, and families don't. And so we have to help them even as they enter a trial, because there's so many unknowns in that. We don't know what the outcome of that trial is going to be. So we may hope for it to be one thing, but let's set the expectation that it could result in another thing altogether. And I think that's the biggest thing. The way we talk about it and the language that we use has to shift towards meeting realistic expectations for families.
Um, yeah, realistic expectations. It's just continually brought up. It's so important. I don't think any of us can stress it enough. Um, that knowing what to expect and knowing that it might not go your way is just the reality.
I mean,
Um,
and science is exciting, right? Like
it's so exciting.
when Dr. Fu called me up and
Hmm.
said she had mice that were living double the time that they were anticipated to live, she was excited and I was excited, and it's exciting, and then your hopes are built up, and then you have to remember the process. And and it's okay to acknowledge the hope while still setting the correct expectation.
Absolutely. Very well put. We do have a question that came in from the audience. And I bet you, Jennifer, you might have some ideas for this, but when someone's actually in a trial, are there opportunities to provide some of that psychosocial emotional support to caregivers during a trial? Just because while you're in a trial, and Dr. Batley, you might also have insight, but it can be really intense or complex, and there's long-term follow-up. And is there opportunities for support during, or ways we could improve that?
I think building some of those relationships as the family is going into the trial is critically important. So having a real conversation with the family, like who are your, I call them your withs, your people who are with you, your supporters that are
Mm,
already there with you prior to the trial that you can activate before going into it. And then having conversations about what things can you anticipate. My earlier example, if you have to relocate or you're leaving one sibling behind, or in the case of one family I know had two affected children, they had to leave the one child with someone else entirely while the other child went through the treatment, and that caused family distress. So as many pre-conversations as you have, but then also I think we have to really look at how the process can be very isolating for people while they're participating in it. We hear a lot about the ramifications of isolation for those families participating. They're not allowed to talk about it, so they're not allowed to talk about the good, the bad. They don't know who to turn to. Often this results in problems because families put things on Facebook they're not supposed to. It's really them trying to say, I feel lonely during this process and isolated. How can I get the support I need? And I think if we do that, they'll be less likely to sort of peter out at the end of the trials when they're supposed to be doing all the follow up, because they'll also um, recognize a lot of the importance of what they have to give back to the community. And I think that's another big thing we could build in is how to help these families after participation be recognized for how much they actually contributed to the science. But it is hard, and we have a lot of videos talking about that on our parents who have done it, been in trials talking
oh,
about those
great.
things.
I think Jennifer said it perfectly. Yeah. Right.
Um, And then, like speaking of being in a clinical trial, like another thing that's come up recently that I've heard of is clinical holds, or what happens when a trial stops. Uh, that can be really devastating for families, and there's a lot of emotion and stress probably going into that. And so, what does that mean, like to have a clinical hold, or why a trial might stop? And then also, is there any like advice or insights you can share?
So, yeah, those are always really frustrating and can be heartbreaking depending on the outcome. But sometimes there could be a clinical hold for things like a concern with safety. Maybe one patient has had an adverse event that, needs to be further investigated. And so, again, I don't know if it makes it better, but to try to understand why there's a hold in the process, that maybe there was something that was concerning the safety, and so knowing that there's a reason for it, although it is still frustrating to have to, wait, or perhaps you were looking to get into that trial and now, it's not enrolling anymore. And so the disappointment is something, again, that we've talked about a lot, and that there's probably no way to make that much better other than being prepared for the fact that that is something that could happen. So it's not a surprise later on. But nonetheless, disappointing.
Yeah, I mean, clinical holds are really onerous on families, right? Also, the family that's currently in the trial is now feeling even more isolated. They're really in a holding pattern. And also, a lot of what goes on during clinical trials feels like a mystery to families because there's so much we can't talk about during the trial, right? Not just the participating families, but even the community isn't getting the information, and that lack of information sort of makes them feel nervous and dubious. So I think the clinical hold only exasperates those feelings for families and for the community as a whole, especially now that we have things like social media where all of that information sort of just lays out there. I think again, it goes back to this is the process. And the more we educate people early on about what the process is and why safety issues, exist. And we also have to be willing, and this is not the case with a clinical hold, but clinical trials end, right? Which also causes the sort of same, in some ways, the same response in the disease community. And so we have to acknowledge why sometimes those end. Sometimes it's financial. And then we have to acknowledge what the families feel, which is often frustration in the process. They've invested and invested and invested, and now it's just for reasons that they often feel are random, cut off. And we have to validate those feelings. They're valid feelings. And do it by explaining why, but they're valid feelings. And I think a lot of it comes from, especially from the participating families. I know we hear this, and this is why my husband and I, when we funded the natural history study, made sure that the data had to be shared with any institution, is families go into this, and when they give you their child, they give you some piece of them. They are giving over something that is precious. And when the knowledge from what that child had to teach the world gets lost because it's hidden behind some safety wall, or some, we can't share the data wall, or whatever we want to call that, or when a trial ends, it's a renewed sense of hurt and loss for that family. And I think too is, when clinical trials end, often families feel like they were seeing a benefit, and maybe it wasn't a measurable one, as far as the endpoints of a trial and what the company was hoping to achieve. And so we have to look at endpoints, and we have to talk about the endpoints before the family goes into it, because they have to really understand that this is what the company is going to be looking for. This is what science is looking for. If we don't get there, this is what happens. um, and that can be devastating. And again, I will point you to the fact that we have a blog written by a mom. It's a 2-part blog about a trial that ended, and you can hear her experience.
Wow, that was really helpful, but the reality of that is it's heartbreaking. And I guess as we're nearing the end of this session, I guess just the last thing I'd ask both of you is if you just have any last advice for either parents, patients, and the providers who are engaging in these conversations, families, if there's any advice or tools to cope during what's usually a very emotionally charged and stressful time, and likewise for the providers to really be supportive and help this process.
First, I just have to say thank you to, our patients and our families who, they trust us with their care and, come see us. And, I just, I'm so grateful for all of our families and, those who participate in research and decide to do that as well, to thank them for, going through this process as difficult as it can be. And I would say, just continue to invest in your support network and your team, and make sure that you have those people around you who, are, supportive and willing to do anything for you. And then to our, my physician colleagues who are going through this research process as well, to continue to stay up to date with what's going on as best we can, because there's so much of it. And to be willing to make the phone call and reach out to each other, because we are also a bigger extension of the team. And, to work together is an amazing thing. And so thank you all very much for giving me the time to speak today.
Yeah, I mean, I think this has been a great discussion, and I would echo what Dr. Bately said, which is don't don't be afraid to sort of admit what you don't know and find the path to where you do know it. And that goes on both ends, the providers and the patients. And and then I think the solutions often come quicker when that happens, because we start reaching out to the other people. It's okay. I mean, in the medical world, I think we're all driven. You got to know the answers all the time, right? And as parents, we also feel that responsibility, right? We have to know this answer for our child right away. So I suggest just reaching out to as many people as you can talk to, gathering information, being realistic about whether or not that information is correct, or vetting it with other people is often a great thing to do at the end of the day. Take something you heard online and bring it to a physician that you know and say, is this a valid thing that I'm hearing, before you decide to go down that path. Bring it to other parents, bring it to your patient organizations, lean into the people that are the best resources to you, and call, I mean, go on to ASGCT. Your videos are so accessible and so easy learning for the parent. And I would imagine for the provider who's just starting out is also going to find them to be sort of a good way to get their path towards understanding clinical trials started.
Well, thank you both so much for sharing such thoughtful information, and you handled it with such care and intention. So, um, it was a really great discussion and to hear from you both. And thank you all who spent time with us today or in the future. Whether you're a patient, caregiver, advocate, or provider, I hope you found value in what was shared today. And it can help in some way when navigating these difficult conversations and decisions. Please know we will be posting this recorded session on the patient education website early next week and sending an email to anyone who was registered when it's available. If you found it useful, please feel free to share it as well. And then the next Lunch and Learn, which is our final one of this series, takes place on December 22nd. And that will hopefully be meet the patients and some people sharing their experiences who've received gene therapy. Registration will open next week, so we hope you'll join us. Thank you again, and I hope everyone has a great rest of your day.